we reinnervate the muscle, the paralyzed muscle. So if someone say nerve reinnervation, that is wrong, because you don't reinnervate nerve. What do you do with the nerve? You regenerate new nerve. Okay, so this is the content, surgical treatment. What is the principle of NSLR, non-selective? The surgical technique, I'm going to show a video, case demonstration, and followed by conclusion. I think Prof. Mawada have given some introduction on unilateral vocal fold paralysis, just an overview. The principle of treatment is to get a firm contact between the two vocal folds, the normal one and the paralyzed one. So how you want to do it? You have to improve the position either mechanically or by reinnervating the muscle. So surgical option, Prof. Mawada has spoken about injection. Temporary or long-term can be done under general anesthesia or local anesthesia. For chronic paralysis, type 1 tharoplasty with or without erythenoid adduction, implant Gore-Tex, and recently we have started doing voice implant, and laryngeal reinnervation, which is non-selective. This is the picture. And remember this, there is no permanent injection. What we have now is either short-term or long-term injection. And for chronic paralysis more than 6 months, we offer permanent surgical treatment. Could be type 1 tharoplasty or non-selective laryngeal reinnervation. So, I want to stress this to all of you. And we also, laryngology in Malaysia, have been telling in our society meeting to tell everyone, especially the youngsters, there is a paradigm shift in managing unilateral vocal fold paralysis. We don't watch and wait 6 months anymore. I hope I don't receive any Facebook Messenger text from patients from other states asking me to do something, because the patient on rise for 3 months, 6 months, not doing anything. So we ENT surgeons, anywhere you go, remember this, we treat unilateral vocal fold paralysis actively. Don't just watch and wait 6 months, because the earlier you intervene, the earlier you give injection or whatever surgery, the better is the voice outcome. And the best bit is the patient do not have to go back home with a Ralph's tube until the aspiration resolved. So for non-selective reinnervation, this is the algorithm that has been used, at least in our center. For reinnervation, you can do as early as on table. If you're doing thyroidectomy, you found the nerve is cut, you can do the repair there and then. Or you can, in cases unidentified recurrent laryngeal nerve injury and become chronic, after 6 months the function didn't come back, although you have helped the patient with injection, early injection, you can perform in delayed type, in delayed duration. And the timing, there is no absolute contraindication if you want to do 5 years of vocal cord paralysis or 10 years. But the best is as early as possible. So the number that we use is 3 years. Anything more than 3 years, we tell the patient, if we do, the results may be guarded, because maybe, not maybe, based on studies, the longer duration of palsy, the less acetylcholine receptor left in the muscle to receive new nerve. And the reinnervation also can be done within the 6 months if you know the nerve been cut and the surgery was done elsewhere. So what is the principle? The principle is you want to restore the laryngeal function by reinnervating the vocalist, the paralyzed vocalist muscle or laryngeal muscles. And how can you do it? By regenerating new axons. How can you regenerate new axon? Is by using a donor nerve. So I'm going to show you a diagram. This is a slide that I told just now, the difference between non-selective reinnervation and selective. In non-selective reinnervation, we want to establish the tone and bulk, regenerating new nerve, reinnervate the paralyzed muscle, and the paralyzed muscle will get back the tone and bulk. Once they got back the tone and bulk, the position also improved, so easy for the opposite side to meet and vibrate. However, synkinesis is inevitable because we don't differentiate the abductor and adductor axon. We just take the main trunk and use a donor nerve to get a new nerve, and commonly done in unilateral vocal fold paralysis. Okay, so this is the diagram showing donor nerve. Normally we use ansa cervicalis and the distal part of the injured recurrent laryngeal nerve. So when you do this, there will be new nerve, new axon regenerated from the donor nerve, and slowly it will grow and reinnervate the laryngeal muscles. So that is non-selective. It cannot, the nerve, the new axon can't differentiate whether this is adductor or abductor muscles. So that's why there is synkinesis. There is no mobility, but there is tone and bulk, and the position will be improved. This is from a paper, Wong et al., which to date, the largest number of non-selective reinnervation been performed. The first bit, the top bit, is before the surgery being done. You see the vocal cord in cadaveric position. There is anteromedial prolapse of the vocal fold, and there is bowing. And phonation, there is phonatory gap. After reinnervation, the bowing disappear, the position improved to paramedian, and the arytenoid prolapse has gone repositioning of the arytenoid. And on phonation, there is closure of phonatory gap. Okay, that is for non-selective, for unilateral vocal fold paralysis when voice is the concern, not airway. In cases where airway is an issue in bilateral type, okay, the problem, the concern is the airway. You want to get back the airway, so you have to return the function of mobility or abduction of the vocal fold. For you to be able to do that, you have to selectively reinnervate the adductor and abductor, especially the abductor, to open up the glottis, okay, so to prevent synkinesis. So people normally use phrenic nerve. Why phrenic nerve? Because they want to synchronize with the diaphragm movement. So every time the phrenic nerve is activated for diaphragm movement, the muscle will be activated for abduction. So you selectively reinnervate the PCA with phrenic nerve. This is just to show a video of a small glottis in a patient with bilateral abductor palsy. So it is commonly done, selective reinnervation in patient with bilateral vocal fold paralysis. So that is not our main thing about the talk today. Now, yeah, we are talking about non-selective reinnervation. So this slide, I want to stress upon how does the non-selective reinnervation improve the tone and bulk and reposition the arytenoid without doing arytenoid procedure. Therefore, I put here favorable position of the vocal fold and arytenoid is a package in successful cases. You reinnervate all the laryngeal muscle, the arytenoid will go back to its position, the position of the vocal fold improve, the tone and bulk improve. This is the patient before non-selective reinnervation. You can't see the vocal process at all because there's anteromedial prolapse of the arytenoid. There's breathiness, big glottal gap, severe bowing. Alright? This is 5 months after non-selective reinnervation. Note that the arytenoid is no more anteromedial prolapse. There is closure of the phonatory gap. Can you appreciate the position of the arytenoid? Okay, and now you can even see the posterior part of the glottis of the vocal cord. And is it mobile? It's not mobile. It is immobile. Position improve, tone improve, arytenoid go back to its position. just good enough for closure of phonatory gap and production of good voice. So that is the principle of non-selective reinnervation. These are the techniques that have been published in the literature. We normally perform ANSA to recurrent laryngeal nerve. So ANSA is the donor nerve. When I come back from the UK, I collaborate with Dr. Yakubu to do a study and learn about non-selective reinnervation. The first thing, what I did when I come back is I approached the endocrine surgeon. That time, Professor Rohaiza. I said, Prof, if you cut the nerve, call me. On table, you call me. I can do something. I'll do either ANSA cervicalis to recurrent laryngeal nerve, or we can do end-to-end repair if you can see the proximal and distal part of the recurrent laryngeal nerve. And I told him, if you do thyroidectomy, neck dissection, please preserve the ANSA for me. Don't cut it. Because that is head and neck surgeon, normally they don't care about the ANSA. So after that, oh, this is Marina. Every time they protect the ANSA for Marina. So the Marina is equivalent to ANSA cervicalis. So remember this. If you do thyroidectomy yourself, please protect the ANSA cervicalis because it is useful if you injure the recurrent laryngeal nerve. Okay, and the other technique is end-to-end repair. You can read on other techniques. So this photo shows which part of the ANSA that you can use. This is a loop, ANSA cervicalis loop. So either you can use the main branch, normally near the hyoid, omohyoid muscle, or if the loop is lower down, and after the loop there is no main branch, but there's two different branches of sternohyoid or sternothyroid nerve, you can use either one. So the caliber is almost similar to the recurrent laryngeal nerve. The nerve, I just want to point here, in cases post-thyroidectomy, to find the nerve over there is impossible, almost impossible because of scarring. So the best is you have to do intralaryngeal dissection, which you're going to practice in your cadaveric dissection. How can you identify the nerve intralaryngeally? By cutting this muscle, which is the thyropharyngeus muscle, and find the nerve behind it when it enters the larynx. Right, so these are the instruments that you need. Of course, you need surgical loop or microscope. You need a small instrument so that you can hold this Ethylone 9.0. In the paper that I've shown just now, the picture of the vocal cord, Wong et al., they use 11.0. I use 9.0. The 9.0, if you drop on the floor, you can't find it. It's very, very small. So what we learn, after like few mistakes before, you must make sure that every time after you finish doing the stitching, the needle, you must take it to the foam. If you lost it somewhere, you can't find. The first case I lost it, we used eye machine, we couldn't find the nerve. We just, oh my God, nothing happened to the patient. So this is a video. I'm going to fast forward, don't worry. You can find the video on my YouTube channel. Every time I go and promote my YouTube channel, and every time I give talk, there's 2 or 3 subscribers appear, new subscribers. So this is the incision that we normally make. The patient would be in an extended as shoulder roll behind the shoulder. Nerve stimulator is basically to stimulate the ANSA cervicalis to make sure that it is functioning once we identify it before we cut. We mark the sternocleidomastoid, is thyroid cartilage, cricoid, so the incision is made just there. And then I play the video, fast forward a bit, then we make the incision, okay, and elevate the flap superiorly until about the hyoid, and below until before the clavicle, so that you have enough space. And then this is sternocleidomastoid. After that, now you can see the omohyoid. Okay, we are dissecting, we can visualize the omohyoid. Then you need to dissect the omohyoid to find the ANSA cervicalis. Okay, so we dissect the omohyoid, and then carefully we see the ANSA cervicalis, which is below there. This is superior, and that is inferior. That is the ansa cervicalis. This is omohyoid. And further dissection, then you identify, that is omohyoid, that is ansa cervicalis. Look that in this ansa cervicalis, there is no loop. Okay, it is the loop is, we can't see it because it's under omohyoid and there is branch sternohyoid to sternothyroid. Then now I'm showing you the intralaryngeal dissection. So this hook is retracting the thyroid cartilage anteromedially, and we are using the diatemy to cut the inferior part of the superior constrictor muscle, which is thyropharyngeus, that is inferior part of the thyroid cartilage. Use McDonald to, or whatever blunt dissection, release the thyropharyngeus muscle, and after that release the piriform fossa. So you have assisted laryngectomy, right? So you elevate the superior constrictor muscle and you elevate the piriform fossa. Similar way until you find the recurrent laryngeal nerve inside there, lying on the posterior cricoarytenoid muscle. So those who are involved in the cadaveric dissection, you're going to practice this. Find the recurrent laryngeal nerve. So now this recurrent laryngeal nerve is cut. Okay, caudally, and then after that, this ansa cervicalis is cut just before it enters the nerve. Alright, and before that we stimulate, we make sure that the ansa cervicalis is working, and then we bring this ansa cervicalis, swing it so that it meets with the recurrent laryngeal nerve that we have identified intralaryngally, and use the 9.0 ethylene under microscope, make it 3 sutures and enhance it with tissue glue. So what I'm doing now is removing fibrofatty tissue to make sure the site that you're going to put suture is clean, not jagged, and there's no fibrofatty tissue there. So then the rest you can watch on the YouTube. And very important, when you do the suture, it has to be epineurium to epineurium to make sure that enhance the growth. So this is the YouTube channel. You can go. This picture shows a delayed non-selective reinnervation, meaning it was not done on table when the nerve is cut. So the video that I've showed just now is for delayed case. And the next photo showed on table reinnervation. You see that there's no thyroid gland. Okay, the thyroidectomy been done, the nerve was cut, and the ansa cervicalis was identified over here, and non-selective or repair is done. Ansa cervicalis to recurrent laryngeal nerve, and then we enhance the suture with tissue glue, like so. Okay. Right, so that is the surgical technique. This photo showing that during surgery, we like to combine it with injection with hyaluronic acid because the reinnervation does not occur overnight. It's not like today, tomorrow the muscle is reinnervated. The nerve grow 1 millimeter a day. So it takes about 4 to 6 months before it reach the paralyzed muscle. So while waiting for the 4 to 6 months, the hyaluronic acid will help the patient's voice while waiting. So some case demonstration, one primary, the other one is secondary. This case, the nerve was accidentally cut during thyroidectomy. On table repair was done, ansa to recurrent laryngeal nerve, and hyaluronic acid was injected. This is her voice.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan mak.
So her voice is not typical of someone who just have acute unilateral vocal fold paralysis, although there is some strain and some roughness. Okay. And this is her larynx 2 weeks after surgery, reinnervation and injection. Okay, there is closure with posterior glottic chink, and there is some hyperadduction of the ipsilateral false chord. This is her voice 1 month of the surgery.
Masa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan mak. Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar,
Can you hear the voice?
abang dan adik datang menziarahi.
So the voice is better. The roughness has reduced and the maximum phonation time increased. This is 12 months after
Masih
surgery.
kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan mak.
The voice continued to improve and improve.
Masih
And this is her larynx 12 months after surgery. Note the position of the arytenoid, the closure, complete closure, symmetrical mucosal wave, and there is no muscle tension dysphonia. So that is for primary case. This is the montage of glottal cycle showing that it is half closed and half open with a symmetrical mucosal wave. So that is primary on table. So remember, if you are doing thyroidectomy, you accidentally cut the nerve, don't wait, I wait post-op, refer Mawada, refer Marina. You do it yourself on table. Our own student, Dr. Shafiq Tumaran, he was in Muar. The nerve was cut and he did it and he sent to us just for injection laryngoplasty and the patient is doing well. This case is delayed reinnervation. 1 month after thyroidectomy, the function did come back. Note the anteromedial prolapse of the arytenoid and huge phonatory gap. There's huge phonatory gap and the patient has really ready voice. This is his voice before surgery.
Saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar.
Just really ready, aesthetic voice, grade 3.
Ayah dan mak.
3 months after surgery.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya.
Voice improved than before, less breathy but still aesthetic and high pitch. And he needs his voice. I was thinking I have to top up the injection while waiting for the 4 to 6 months. So we were having busy clinic. I cannot inject you today, come back. When he come back,
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan mak
That
tinggal
is-
di bandar. Abang dan adik saya tinggal di bandar bersama ayah.
4 months after the procedure. So we abandoned the plan to re-inject. So do you think that is the effect of hyaluronic acid? That is the effect of reinnervation. I've been contested by surgeons whenever I present this. How do you sure that this is not the effect of hyaluronic acid? Okay, since this is an example, another example is we have to show the reinnervation on laryngeal EMG, and his voice continued to improve.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar.
He get back his voice. Recently, I met him 2 years already after reinnervation. The voice still okay, but unfortunately, he was diagnosed to have motor neuron disease. But his voice still good, just other muscle. The vocalist muscle still okay. And this is a montage of glottal cycle, half open, half closed. I have a little bit of time just to show some data. In primary reinnervation, we can see this kind of trend. After surgery, the voice is okay in terms of voice handicap index 10 and maximum phonation time, but around 3 months, we can see worsening of the voice handicap index 10 because of resorption of the hyaluronic acid and reduction of the MPT. But after that, the voice improved again because of the reinnervation. Okay, this is the trend that we observe in primary reinnervation. And we also have compared the result between non-selective reinnervation and type 1 thyroplasty. We found that although in both group voice improved, but at 12 months when we compare between these two groups, the voice handicap index is significantly better in laryngeal reinnervation group compared to the type 1 thyroplasty. The voice handicap index then and maximum phonation time is significantly better. Of course, when we did this study, we standardized the age. So we exclude all more than 60-year-old. We only take those duration of palsy 3 years or less. So we standardize that to reduce bias. And recently we have collected all our cases to see the long-term outcome. Of 25 cases that we have done, is already 12 months. The voice handicap index then, the maximum phonation time and acoustic analysis, all good, still stable, and all showed that significant improvement compared to the baseline. And when we compare, when we look at the primary, so there's 25, there are two groups within the 25, the primary, on-table, reinnervation and delayed. We found that in primary non-selective reinnervation, there is no significant difference. When we look at the trend of the voice handicap index, then maximum phonation time. Why is it so? It shows that the patient happy with the voice, although the nerve is cut, but because you intervene early, the atrophy doesn't really take into place, and then we inject the muscle, the vocal fold, so the voice remain good, throughout until 12 months. And when we compare between primary and secondary group, at 12 months, the voice are the same. So it doesn't matter if you do secondary, but the primary will get the benefit 1 month, 2 months, 3 months until 12 months. So do as early as possible. So in conclusion, the injured recurrent laryngeal nerve, if you injure, there is propensity of regeneration. But many of them, the regeneration is suboptimal and the voice is bad. Therefore, you can perform surgery in chronic paralysis, either type 1 thyroplasty or reinnervation. If you do non-selective reinnervation, there would be synkinesis, no mobility, but there is tone and bulk and improved position and reposition of the arytenoid. Hence, you can get a good closure between the paralyzed and normal vocal fold. And because when you do this non-selective, the nerve reinnervate not only the adductor muscle, but also reinnervate the PCA, the posterior cricoretinoid. The posterior cricoretinoid, the function is not only causing abduction, but to stabilize the position of the arytenoid on the shoulder of the cricoid cartilage. Okay? With that, thank you so much for your kind attention.